So before we get started, I'd like to welcome our impressive panel. And you can find all of the speakers' bios. Their full bios are available on the Southern California HIMSS website. So for all the information on our speakers and our slides will be available in a few weeks. You'll be able to get everything there. So we can start with Dr. Swamy.
Hi, everyone. Good morning. Good morning. Sorry about that. My name is Swamy. I'm a radiation oncologist as well as a medical director for diagnostic imaging for Epicare in the Bay Area. We're a large independent physician practice of over 70 physicians of multi-specialty, medical oncologists, radiation oncologists, surgeons, and some primary care as well. And thank you so much, Midori.
Hi, I'm Eijean Wu. I'm a gynecologic oncologist. I'm a partner in a medical group of 11 gynecologic oncologists working in the LA and Orange County area. We're a private group. That's basically it. Thank you.
Hi, I'm Tracy Donegan. I'm the Chief Information and Innovation Officer of Martin Luther King Jr. Community Hospital. I've been in the industry for like 30 years and was part of a small group that built the hospital here with Paul Butler over there. I don't want to embarrass him, but it's a pleasure to be here. Thank you, Midori.
I'm Amy Miller. I'm a cardiovascular electrophysiologist at Brigham and Women's Hospital, and I'm the associate CMIO of what was last week Partners Healthcare, and this week is apparently Mass General Brigham. Thanks, Midori.
My name is Priti Lakhani. I'm actually a podiatrist, surgical podiatrist, and I am the Chief Medical Information Officer at Einstein Healthcare in North Philadelphia and Montgomery County in Pennsylvania, and former Cerner physician executive. Former, so you cannot throw tomatoes or rotten eggs at me today.
Well, thank you all for being here. So we'll start out with really the million-dollar question: what is digital transformation? So you can just answer, whoever wants to jump in. What does digital transformation mean to you?
First implemented our original EMR and then installed Epic several years ago. We were essentially translating what we'd always done in paper into the computer. So this is what a note looks like. It will look like that in our computer system. To me, digital transformation is breaking away from the way that we always did things and figuring out how we can do them better for our providers, for our patients, and truly change the way that we deliver care so that we're not practicing 1970s, 1980s medicine in a computer system, but actually practicing in a digital fashion that's more efficient and more effective.
To me, digital transformation is either radically or practically changing a process or a service you deliver for a specific reason. I mean, there has to be a problem to solve. And it also involves, having an impact on the patient or consumer in a way that removes barriers for them to get better access to care, whatever they need.
So I think just because of my, my generation is, I've gone through multiple, I've experienced inputting of Centricity, Cerner, Epic, Athena Health, NextGen, Onco EMR, and I think I'm forgetting one. Oh, Paragon and Meditech. Those are all the systems that I've had to survive in the last 10 years. And in that process, digital transformation has meant for me that since I cover multiple hospitals, instead of having to physically go to all of those places to obtain records, it's allowed me to at least remotely check on my patients, put in orders, and obtain information from multiple systems. So it definitely has changed the way I'm able to practice and gives me an ability to scale the services that I'm providing, but it has also presented new challenges for how you can integrate all of those different systems.
I think I have two things here. One, what should digital transformation mean to me and what it has meant to me. I think what it should be is really enhancing the workspace that we're in, whether it's for the physicians, whether it's for the patients, whatever it is. Rather, what it has been, I would echo Eijean in that it has helped in some ways, especially I think probably my favorite part about Epic EMR is care everywhere. However, it has presented great many challenges, and I think that is what really needs to be looked at in terms of, is it actually enhancing our workspace or whether it's creating more challenges.
I think it's interesting. We're all looking at it from our own perspectives, right? Being physicians or being in technology or being in administration. But I really approach that question from a patient perspective. And from a patient's perspective, the three things that I hope that it means is to improve outcomes. So for example, earlier diagnosis and protocols for sepsis, improve the patient experience. So as we all know, we're sort of held to a Press-Ganey standard, right? And so service recovery perhaps is much more enabled as a result of digital transformation, and using data, changing data to actual information, right? Your Fitbit or your Apple Watch, when a patient comes into you and says, I've noticed my heart rate jumps really high when I do this. That's information that's been gleaned from data. That's digital transformation.
Oh, I want to piggyback on that for a moment. I think for me, the ideal state for digital transformation would be that whatever tools I have to manage all the information that I need to process allows me, as an oncologist, to be able to spend more direct eye-to-eye time with a patient, actual face time with them in a room, because ultimately that is going to be what's most important to that person.
Thank you. We've got a great lead in here around the patient experience. And this has been, a topic for now many, many years on, how are we doing with the patient experience? And really, have we gotten to the level of where patient engagement is actually possible with the tools that are out there with digital transformation? Can you talk a little bit about what strategies your organizations have done to help enhance that patient experience?
Well, here at MLK, we were doing a digital strategy one day. I got the executives together in my office, and the CMO said to me, well, it's not about what we do for our patients, it's actually what they need from us. And I thought that was the most profound statement, because we're always, there trying to do what we think they need. And it turns out that's really not what they need. They need something more. Case in point, we went out into the community to solve a transportation issue, because patients were missing appointments here and there all the time, and it was really hard to handle. So we sent a team out, did a human-centered design approach to figuring out what really they needed, and they needed a lot more than just transportation. Wasn't really their issue. It was an issue, but it wasn't the only issue. And we've got some great insight that we still use from that experience. But for us, patient experience is, really getting to know what the patients need from us and what will better get them to engage better in their care and to really own it.
I think for our organization, it's been really focusing on the people that are delivering the care for our patients. So whether it's the frontline staff, whether it's the technicians, whether it's our nurses, and including our physicians. So getting the tools to them in terms of making sure it makes their job easier. So whatever digital space that we're using, for example, in imaging, we're working with our PACS system to ensure that it's optimized, to make sure that our techs are, it's easy for them to use, getting those images to the patients. Most interestingly, one of the things that I think across industry we have is results being released early. And I think that's something where we have the tool to do it, right? We release the information. And as a friend of mine told me this, kind of digital transformation is getting the right information in the hands of the right people at the right time to make better decisions. And it goes back to people, and I always look at digital tools as just enhancements. And for our organization, it's really enhancing the people that are taking care of the people that we're trying to take care of. So taking care of our staff so that they can take care of our patients.
I think a good example that we can all relate to is telehealth. That's something that's really improved the patient experience, and it's actually, frankly, improved, for the most part, the provider experience, right? Because we have providers that, for whatever reason, can't get to work, or it's hard for them to get to work. They can answer calls sitting at their desk, or answer emails, or do a face-to-face Skype visit. And then the second thing, that this is a small thing, but it's really helped in our organization, is the Pre Visit Questionnaire before the patient comes in, because it allows us to order pertinent labs before the appointment, so you don't have 2 appointments. You have the pre-visit lab questionnaire, it's reviewed, the labs are ordered, and so when you come in to meet your provider, that 15 minutes that you have with the provider is really efficient and effective use of the time, and the patient feels like their problem was solved. And it began, the whole journey mapping of when does a patient experience begin. It isn't when the doctor's in front of them, it's when they log in to make an appointment or call in to make an appointment.
We've put a lot of effort recently into trying to deliver more electronic tools to patients so that they can do things online, so that they can do things on their phone, accessing information, scheduling appointments, updating their own charts. At the same time, we're trying to be very cognizant. When I go to get gas, I love to pay at the pump. When my father goes to get gas, he hates to pay at the pump. He likes to go inside to talk to the person who's working at the register. And we can't lose focus that not all patients want the same thing from healthcare, experience healthcare the same way. And so we can't really get trapped by the allure of digitization and expect that we're going to make all patients happy by letting them do all the work for us, which in some ways some of these digital tools lead us to. I think the other thing Priti mentioned, providers. So we have intentionally called the pillar that focuses on patient experience, not patient experience, but experience, because we believe that provider experience is critical to patient experience. If we have happy, engaged providers, they will provide better care and better support of their patients. And we don't want our providers to think that we are focusing on patient experience at their cost.
I think it was a great kickoff keynote speaker you had, because he really set the foundation for all of this stuff that we're discussing, right? Taking into account the end user, considering the experience, all of that. That's exactly right.
Yeah, I wanted to build on what you were saying. Just when I said it's all about what the patient needs, I'm not talking about, we all know what the digital technologies are out there. There's no sense mentioning them. But what's important for our organization is the adoption. Is our population really going to adopt them? And this is where we're struggling right now, and where we need to invest our money. Telehealth is great. It's going to help us. Pre-visit, maybe AI-enabled texting would help. We're at the point in our organization where we're trying to figure out what's really going to help our patient. They want, first and foremost, they want respect. They want to be treated with respect, and they want a relationship, or actually, we need to make them know what a relationship is like with a physician. There's so much we need to overcome that's not technology-based, and I want to use technology to help overcome and change the mindset of them. It's just which ones do we invest in first is really my issue.
Thank you. Sorry, I was just going to ask a follow-up question. Tracy, you deal with health disparities at MLK. I know that you've been working a lot on these initiatives. What challenges are you seeing with health literacy and other things? And I think, Eijean, you also, in your downtown LA practice, see some of the similar issues with patient literacy, and that empowerment of patients sometimes isn't what we think is going to empower them. Can you comment, both of you, on that?
Well, I was actually going to say something related to that. The biggest challenge that I face in my practice, the obtaining of medical records, that's been out there, we all understand that. But the biggest challenge that I actually face is in the insurance administrative burden of getting a cancer patient through their entire journey. They need authorizations for lab work. They have to go to the right lab. They have to go to the right imaging center. That needs an authorization as well. They need to go to the right radiation oncologist, the right, the chemotherapy. Getting one course of chemotherapy is about 25 codes that needs to be inputted, that has to be inputted correctly. Payers change the codes all of the time. So that has to go in correctly. And then obviously all follow-up visits require another authorization. If they see a different provider in my office, even though they're also a GYN oncologist and we're under the same tax ID, we have to change the name on the auth to that provider's name, or else the billing won't come into that correct MPI number, and that person doesn't get credit for having seen that patient on my behalf. And so all of all those administrative steps, I think, often frustrate the patients a lot. What we have really focused on as a medical group is to take that to basically allow a patient to walk into our office. I was able to do this yesterday. Somebody called me from an emergency room, said, I have this patient. She has HealthNet Medi-Cal. No one will see her. We don't know if anyone would accept this patient. Do you take this insurance? And I have the privilege to be able to say, we'll figure it out. Just have them come to my office tomorrow. Dr. So-and-so will see her. We have a financial counselor. We will work through each of those steps with them, and we'll work through whatever authorization process is needed so that we can get this patient whatever they need within a 2-week period of time, which is generally what a cancer patient needs. Otherwise, obviously, this is very obvious. If they're waiting months and months to get through all those administrative steps, their prognosis is going to be very, very poor. So to be able to do that, we need a lot of digital tools. Every single payer, I don't really burden this, but there is a health plan level of billing, and then there's an IPA level of billing. IPAs are for medical providers, et cetera. So we have to actually send paperwork to both of those different levels, figure out which level they're supposed to go to so that our practice actually gets paid for the services that we provide so that we can continue to provide services. If we do it to the wrong place, the authorization won't come through and the patient won't be able to go to an imaging center and actually get what they need in the time period that we want them to get it. So there's a lot of details and pieces here, and our financial counselor has a list of all of the websites for all the different portals to access all those health plans and all those IPAs, of which we have about 100. And they have to work through that for every single patient to make sure that they actually just get the very basic standard of care we would expect for all cancer patients.
So I'm sorry, Midori, if I could just add something onto that. So I think this is an excellent, I'm obviously in the cancer space as well, and I've had the privilege of working with Eijean in the past, and her and her staff do a tremendous job of taking care of the patients that no one else will. And I think that's really where digital tools can help. When you are with large healthcare systems, there are teams of people often that are doing this kind of work for the physician and the healthcare system. But that also results in higher, and I think one of the things you had maybe asked us about is cost of healthcare. So there, at the same time, when you deliver care in these large healthcare systems, the cost also goes up. However, getting those digital tools into the hands of private practice physicians where there is true value in how we deliver the care, whether it's the human touch or whether having the flexibility of seeing any patient, having that ownership to say, it's okay, we'll figure out how we're going to take care of this patient. I think that is really something where digital tools can come in and helping out private practice physicians and their teams, because human capital is expensive. And for private practice to take on that level of capital, that's why we're seeing, or at least that's one of the reasons we've seen dwindling of private practices and, you know, cost of healthcare going up. That's just one little piece. But I think that's where the digital tools can really help as well.
Well, I agree. I think with our population being so underserved, it's really a challenge to figure out what will impact them and what will motivate them, or actually not even motivate them, just remove some of the barriers they need to access care. I once had to give a talk around Maslow's hierarchy of need, and they gave me the highest one, which was self-sustainment. I think that's the one. And I'm thinking, why are they asking me that? I mean, I'm not even in a community that can self-sustain. And I realized that it was all about getting up and taking care of all those basic levels of care in order to get that. And I can't believe I just learned that like about a year ago. But it's using those tools, whatever they are. I mean, they could just be community portals or, you know, motivational tools to help behavior. Help motivate behavior. I mean, there's just a myriad of things that you could apply to move people up the ladder and help enable the physicians to do so and to care coordinate as they can. So there's just so many ways I can answer the question. But in terms of, you know, the community that we are in, it is challenging to figure out just exactly what will work and what tools to apply.
I work in North Philadelphia, which has a similar makeup as Compton. And I will tell you that the best lessons I learned about health literacy came from being the person that translates health for my parents. Because they're not in healthcare. They didn't grow up in this country. And so I wound up being the translator very young for the language, and then as time went on, being the translator in health literacy, right? Understanding that a stroke is like a heart attack in your brain and explaining it that way. But the one thing, Tracy and I had this conversation last night, is we've gone to less language and text, and we've gone more to picture and words and videos. And that's really helped to convey really important healthcare items. We switched our, for example, our congestive heart failure discharge instructions from text on paper to videos and pictures, and it was surprising how many more people responded to that and asked questions about the pictures and would never ask a question about the words that were printed.
Great input. You know, Eijean talking about the whole payer issue. You know, this session's really around how do we align payers and providers in this digital health movement. And I believe that there's this whole thing that even the most educated of people have an issue with, and it's the insurance literacy. There's lots of folds and lots of different things, different rules, different lists, different things that people need to do. What would you all recommend for the payers on what should be some top things that they should be working on in the digital health space to help support this insurance literacy issue?
I don't know where to start. There's so many. I'm going to put my filter on. You know, I think it would be, okay, if we lived in utopia, right? It would be really wonderful if the insurance payers, and this is starting to happen, right? I don't want to beat up on the insurance payers too much, but you know, if they had the same investment in population health that we do. We all know that the average time span for a patient to stay with an insurance company is about 3 years, and it takes about 7 years to really make population health changes. And so, so there's a misaligned incentive there. So without getting into politics and you know, a whole morass of really charged questions, I think that actually, in fact, I'm heartened by some of the ways that payers are reaching out to provide coordination of care, because basically what they're learning is, right, they cycle through my insurance company at 3 years, they go to a different insurance company, they go to a different, they go to company B, they go to company C, then they come back to me and they're sicker, right? So, so I've noticed Blue Cross Blue Shield, Aetna, Humana doing some really great cost-cutting things. Humana's got a great program called the Bold Goal 2020 to decrease health disparities by 20% by 2020 that they've been doing for, I think, about 7 years, and to improve healthy days. They've had a movement of a half a day, which doesn't feel like much, but that equals out to like $40 million realized in healthcare. So I'm heartened. I'm cautiously optimistic.
I think a really basic thing that I see often is a patient will bring me an envelope that has a thick stack of paper that is essentially their authorization for being able to come and see me. And it's about 10 pages long, double-sided, single space with the information in, it's just all text, and they do try to do it in multiple languages. So there's, I mean, in LA, we probably have like 10 languages on that. And a patient will just bring that to me and say, oh, I got this in the mail. I don't know what I'm supposed to do with this. This is a really, really simple thing. I think most people, when they're signing up for a payer, they have to say what their preferred language is and their preferred form of communication. You know, for a while, I didn't have someone in my office who spoke Korean, and if you know LA, there's a very, very large Korean population there, and we had to communicate with our chemotherapy patients just using like Google Translate on a smartphone. Just to make sure they showed up for their appointments and such. And so, but anyway, so my point is that with these large stacks of paper that these patients are getting that basically tells them that they can go make an appointment now, a digital solution could be that they should just get it in the language that they need it in, that they don't need all 10 languages, and then they're just frightened by like the sheer volume of the paper they're receiving and they don't know what it's saying. It just literally has to say, this is the place, this is the doctor you're seeing, here's your appointment, it's approved. You know, and in their language, it can just be one page, one-sided.
And I've seen plenty of those packets as well.
With pictures.
Yeah. I think one of the things from a patient perspective, and also having family that's not necessarily health literate, is there's so much paperwork, so much that's coming at them. I often tell my patients, again, in the cancer space, you know, I say at the beginning it's like drinking out of a fire hydrant. And it is, because they have to process the information that they're getting about their diagnosis. Often with complex diseases, they're seeing multi-specialty physicians, all saying multiple things. Often it's time sensitive, so meaning decisions have to be made in a relatively short period of time. And then there's paperwork coming at them from all different places. You have healthcare systems, you have doctors' offices, you have imaging centers, you have lab, you have payers. And I had a patient recently that told me she had 29 phone calls within a span of 2 days, and she had 5 different appointments that she needed to make. And she pretty much called me and said, I'm not going to anything, I'm not doing anything, I don't know where to even start. So I basically told her, don't return any phone calls, just come to my office. But I do know that is it really needed to send all that information from the payers to just let them know something is authorized? Because obviously it's going to the medical offices as well, and appointments are being scheduled. Often these letters come sometimes a month after stuff has already been done, and then they're going, wait, what is this? I thought I need another PET CT? No. So, I think we really need to evaluate, at risk of overly sort of giving information. I say the reason that we all went to school is to partner with our patients to help them make decisions. We're not going to tell them what to do, but we're not in a business of selling things and going, here's 5 things. This is good and bad about each thing. Now pick. What? Which option should I go with? That is not my job. That is not the type of, as a physician, that's not how I view. Certainly we talk about the pros and cons of each options, but my job is also to evaluate what is their goals of care, what is their background, what are their fears, what do they wish to accomplish, and help them demystify these options and come to something that they may want for themselves. So I know we started with the payer thing, but I think it's for physician offices or healthcare systems as well. We really need to curate what information that's the most meaningful for patients, and how can digital health help with that.
I think in terms of curation, the other piece is when you think about the patient's chart, how much of the information in the chart is for the patient's care as opposed to for the payers and for the regulators. And I've had coders say, well, you're not documenting these things, don't you care about the patient? And I say, those things have nothing to do with the care of the patient. That has to do with us getting paid, which I agree, no margin, no mission, and I'll document them. But that's for the payer, and we've really corrupted the chart to become more of a financial record to justify why we're getting paid as opposed to what we're actually doing for the patient. And that means that our providers are swimming in this sea, this morass of noise, trying to find the pieces of the chart that actually matter so that they can deliver the care that the patient needs.
And Midori, not to steal your thunder, but what Uma said, what Eijean said, and what Amy said, now do you see why we're burned out? This is not our job. My job is not to sit with you and go try and figure out where you're going to go for your bone density scan. But I, as a person who is, think of my job as not a job but a vocation. And my vocation is to make sure that you have a good healthcare experience, or that we're taking care of you spiritually, socially, physically, psychologically. I'm spending my time going through all your papers and figuring out what you need to do next.
It's actually a great lead-in. For many of you, a lot of the topics that we're covering here have to do with the quadruple aim. And so there's a focus on patient engagement. There's a focus really on cost-cutting strategies but still also improving patient outcomes. There's a piece on population health, and also this burnout that we're seeing with our physicians and our care teams, and really a lot of staff just in health systems through the administrivia and the paperwork, and just trying to make sure that things are dotted and crossed. And this is become a really big concern. Doug was talking earlier today around turnover rates. And we see, in various different job roles that there's actually a really high turnover rate. And, a lot of them actually have to do in the revenue cycle departments and patient access. But also, we see that our physicians are burnt out. And, a lot of times they're asked to meet certain productivity, but, there's not enough resources. So, and leading into that, there's also been other strategies to talk about how to handle this burnout, or what should health systems and provider practices think about? One of them was mentioned around care coordination. There's been some discussion of scribes. What are some other strategies or things to help to support the staff and the physicians in taking better care of the patients?
So one of the words that, instead of the word burnout, I've heard the term moral injury. And I think that actually describes what many of us go through. So it's this whole thing about finding purpose. There's a purpose for why we went to medical school, or why some of us are in administration. There's a purpose to it. So when that purpose gets misshapen, or you're not really working to your fullest purpose every day, you feel disengaged. And so I think if, there are a lot of well-being committees at different hospital systems. People talk about going to yoga and meditation. You already have 50 things on your list between, that you're trying to do at work. Then you got another 50 things to do at home. And now you want me to go to a yoga class that I got to fit in? And that's going to somehow miraculously take care of everything that, or actually help with what I'm feeling. I think, as one of the speakers earlier said, it's about what do your physicians need on a day-to-day basis to help them get back to their purpose. I can tell you it's not yoga or meditation or any of those things. It is helping your physicians getting back to their purpose, and whether it's human things that need to be done, whether like scribes or digital tools, that's going to help them get back to their purpose.
We've been working to try to leverage our systemness, if you will. So, historically, if you were a patient who needed a rectal MRI, that can be done on any scanner. If you go to one of our community hospitals, it's going to be read by someone who almost never reads those studies. Or we can make you as a patient come into Boston and deal with the traffic to be seen at one of the academic medical centers. But we have the capacity now to let you have that scan done anywhere and have the right doctor read it. So we're not constrained by you're at this clinic, and so this is the small population of people who have to do everything for you. So how we take advantage of the scope of our system and the various expertise and roles to truly deliver the right care at the right time without making the pieces move in a way that is disruptive to them. And we think that that is going to be beneficial to patient care and actually improve provider experience, because they're not trying to kind of manage things that they shouldn't have to.
At one of the hospitals I worked at, not the current one, we underwent a whole improvement of physician experience. We did all sorts of user interface changes. We had a whole list of things we did. And the two highest actually, I'll tell you the three. The first one was digital. I'm from Kansas, so we gave the ability for specialists to reach out to critical access hospitals and offer care. They loved it because you could be in a critical access 20-bed hospital and speak to a high-risk neonatologist or high-risk OB easily. For the high-risk OB, that was very satisfying. But the second thing was providing daycare for sick kids so that doctors could come to work and drop off their kids. It seemed like a no-brainer. We're a hospital. We should be able to take care of a kid who's got a flu or a fever. And the third thing was being able to bring your dry cleaning and drop it off and pick it up at work. So, here we are talking about these lofty things. Like, truly, we were talking about user experience and how do we get bigger monitors and change the color of the screen, and it was dry cleaning. It was, yeah.
My only message here is just to be thoughtful about the types of technology that you're putting in place, because I obviously can't speak for you all, but that would be my advice.
Yeah, I think one of the tools, I'm working in a clinic at California Hospital, and a very generous donor gave the hospital a very large number of electronic translator, iPad stand things. I don't know exactly what they're called.
Marty's?
They
Marty's?
Could, yeah, they could be called that. I don't know
Okay.
what they're called. And it was, it was supposed, we can't always get the translators that we need for so many languages of the people who are coming in. And it's been interesting to see the use of these tools, to see whether or not they actually are being used and if patients are able to interact with them. I mean, my personal experience with it has been, because most of my patients they're sick and they're older, of that it's actually difficult for them to interact with an electronic interface, or they can't hear it because we're using it in a space that has a lot, like in a preoperative area where there are a lot of other patients as well. They can't hear it, or they can't quite understand it because of just that digital translation. The face is just not placed correctly, or they're just not comfortable using that technology, actually. But the thought would have been that, well, everyone has a smartphone now, you can FaceTime, all of that, but it actually has not turned into something that has worked well, and a lot of the patients, of course, would still prefer to have an in-person translator than to use that technology.
So we have one area that, and actually Tracy, you hinted on this for population health, and obviously oncology is a population, but there's also chronic diseases and other populations. What do you think can be done to enable really the population health movement? It really, we've been talking about it a long time. It really hasn't completely taken off the way we'd like it to. I do think that there's some care models that have been out there to actually help patient-centered medical homes, actually the oncology care model. What do you think we can do with either services, since we're also talking about resources to help support care teams, so care coordination hubs. Tell us a little bit more about what you think can be done in the population health arena.
Well, first and foremost, data aggregation, for one. I mean, in order to, deal with the population, you got to understand who you need to help. So that's first and foremost. But I love the idea of a hub. I love the idea of a command center. And I think that we're trying to work towards that because there has to be a way to curate the experience, especially for us because, we're a small standalone hospital. No one wants to take our patients, so we got to basically find a way to develop those post-acute care services and higher level care services so that we can put a patient somewhere. And in order to do that, it's going to result in a very disjointed, system. So we need some way of pulling all the pieces together, and that would be a good solution. But with data, care coordination, the right tools to interact with that, the right people, all the normal stuff people would say, to answer that question.
I would agree. I think that we've had physicians clicking around computer screens for several years, many years in some cases, and we've been slow to leverage that data and actually achieve the power that it offers us, both retrospectively and prospectively. And I think that everyone now is kind of understanding that that is what is going to drive this. We have this amazing wealth of data just waiting for us to take advantage of it. So I'm hoping that we are on the precipice of actually realizing that.
Can I ask a question maybe between what you guys are doing? So one of the things is we have all this data that's somewhat siloed, right? I mean, you have Mass Gen, you have MLK, you have, every Stanford has their system, but I'm just wondering, is there any? I know there's been some talk of certain systems combining data to really leverage that, but can you maybe, since you're working in that, I'm just curious.
Yeah, so we're an Epic site. Epic has an initiative called Cosmos, which would take de-identified data from their customers who choose to participate and create a shared data source that people could use. They have several customers who are now contributing and are hoping to see it grow. I think it's a very interesting and attractive concept. I think there is at the same time a lot of concern, and you might even say paranoia, as you see headlines about data breaches and did Google really have permission to share, that type of thing. I think that the healthcare industry is very cautious because of that. So it will be interesting to see how quickly Cosmos takes off, but the potential power of it is amazing.
There's just so many problems you need to solve before you can do that. I mean, you've got all the patient identifiers, right? You got to be able to identify which patients belong with who, and then you want to be in control of that, you know, that methodology. So that, for one, is one. And then it's not just about getting the data together, but it's the right data, because you could have all these different you know, pieces of information from all these different providers, but it doesn't mean anything if you got to click on a PDF, like 5 of them, to try to draw the storyline from it. I just want to add, though, the one thing that we are trying to do is also add other elements of data to our medical data to really form and decide what action to take. I mean, the case in point with the flu epidemic, we knew it was going to be here sooner, and it was going to be a lot worse than it was before. So we took our data, we did some spatial modeling, and determined that, and this is just practical stuff. I mean, this is population health at its most practicable element. But we identified 7, you know, neighborhoods where there was a big incidence of flu, and we partnered with those community organizations and leveraged the activities they already had planned, food drives, turkeys, you know, sharing gifts and so forth. And we're partnered with Cedars and LA Public Health, and we're providing early vaccinations. And I mean, that is going to have a great impact, and it was not very hard to do. So I mean, that's where the power of population health can be without this fancy, you know, data aggregation and all that other stuff. That's really hard to do. There are some basic things you can do to solve some issues.
I think in some areas, so I'm a cardiologist, and so the American College of Cardiology has the NCDR databases, which have allowed us to accrue information from a number of institutions across the country, which is great. At the same time, if you look at the way that people capture data for NCDR, it's almost like a parallel thing. So there's documenting for NCDR, and then there's putting it on the problem list. And so often they're documenting it for NCDR, but they're not actually documenting it where they should in the patient's chart, because NCDR they get graded on, and the chart they don't. And so I think we need to find a way to better use the information in the chart, as opposed to creating these tools for data aggregation that end up creating silos of their own, unfortunately.
There's so many things I want to go into, but I know we have different sessions later. So I'm going to leave this to the EMR vendors and digital health vendors. What do you think is working and what's not working in this space? You talked a little bit about, obviously, you know, the silos and different builds that happen in the EMRs. There's different data projects that are going on. But as we really think about the people that do use smart tools or digital tools, how do you think that the EMR vendors are doing in this space?
If only they can live up to their promises. I mean, that would be really great. But I mean, they're doing a lot of, I mean, we were just talking to our Cerner partner in a meeting. I asked her this question because I really didn't know the answer myself. And she said, you know, we're starting to do a lot of partnerships, and we're moving away from investing our own money into these solutions. And I think that's the right approach, if only they can get the integration right. I can't tell you how many times that we've paid money for a solution, ending up having to shelf it or make it work on our backs for everybody else to have it work for them. So I think partnerships is the right thing for them to do. They certainly cannot move fast enough as some of these other nimble companies, these other startups. But if they can just get that integration, interoperability right, I'd be very happy.
One thing that I think that has been enabled by EMR vendors, which we did not have before we had a chart, was asynchronous communication. I mean, I started my practice on a paper chart, and when a patient came in, they would have this list that they would want to go through with me. And it's so nice now. I can text my physician, I can email my physician. It usually goes to the nurse, and then she parses through it and decides what the doctor actually has to answer. But that's really, I think that's something we take for granted that wasn't available to us before. I think that the other thing that's happened is, as a result of EMRs, everything is discoverable. There's a positive and a negative to that. Let's focus on the positive, which is that we have more accountability for evidence-based medicine. We have the ability to track if you are following a protocol that's well known in the community. When I started practicing, if I sent the same patient to an interventional cardiologist X, one of them would have an amputation, and why they wouldn't, because they just practiced differently. Not because a patient was any different, not because a protocol was any different, they just practiced differently, and there was no way, short of sitting through and going through charts, to figure out what they were doing differently. Now we can do that fairly quickly. So that's something I think that they're getting right. Being able to, I hate this word, but it's correct in this way, is mechanize protocols.
I think when we installed Epic, we took our first site live in 2015, so we've been up several years, and it's been interesting to see how they've evolved since we went live. We were talking before about how when you've seen one Epic install, you've seen one Epic install, right? You go to each hospital, it looks totally different, and everyone does things totally different. And I can say from our experience, part of that was us. We would say, we want to do things this way, and Epic, in their very Midwest nice, would say, we really don't recommend you do that. And we'd say, we're partners. We know what we want to do. And we made a lot of mistakes because we didn't listen to their gentle, maybe that's a mistake, and we've had to rip out a lot of that build. But a lot of it was also just that at the time we installed, there wasn't kind of an academic medical center build for a lot of things, and so we had to create things from scratch. And I think Epic has, over time, become more delivering foundation and trying to get you to stay to foundation. So hopefully, over time, that disparity in the experience across sites is going to go away, except all of us who are already live then have to remediate and go back to foundation in some fashion, and I think that will be a challenging experience. The other piece of that is that for the provider, the EMR tools historically have been kind of pluripotent. So you can do it this way or you can do it that way. You as the provider can decide. Thinking that providers like to have that freedom of choice, that ends up creating a lot of heterogeneity in the chart and in the user experience. And so there probably is a need to be more directive. And certainly individual sites can do this, but I think the EMR vendors could also do a better job of, we're not going to give you 10 ways to do this. This is the way in our system that you should do this. And I think that people will actually like having that direction as opposed to being lost in the freedom that we give them.
I think for in surgery, because it's one of the most frightening experiences for anyone to have to go through. You're under anesthesia, you don't know what's going to happen to you, there's a whole team of people involved, it's very costly. What the information and the technology allows is to have some level of insight into what is happening in that entire experience. Like there are things that, and ultimately to hold the physicians accountable at all, because really you never know what your surgeon is doing. And in a lot of hospitals, it could be difficult to know, why does XYZ surgeon do the same procedure and it costs they use $10,000 worth of equipment and another surgeon is using only $5,000 of equipment, but the information would allow us to put those pieces together between cost and then the outcomes and figure out, what might actually be useful feedback for these two physicians. And it also allows me to know, like, over time, are my patients doing really, really well? When we have big practice changes, and very recently for GYN Oncology, there's a big practice change in how we perform surgery for cervical cancer patients. We would want to know going forward, how has this impacted patient access, cost, and actual survival outcomes?
So as I asked this last question, we have a few minutes for questions. There's mics on each end, and we have runners actually with handheld mics. So if you have questions, please head to a mic or raise your hand so they'll bring the freestanding mics to you. And this is the last question while we get our folks prepared to bring those mics out. How do you think digital tools can help with now the new shared decision making that we're talking about? What do you think could be done to help expedite and support patients and providers and in that journey on moving towards shared decision making?
So I think, as Priti alluded to earlier, the ability to be much more visual in what we provide patients is critical to shared decision making. My aunt was in the hospital several years ago, and they let my cousin record an audio tape of the physician talking to my uncle. And the physician did an amazing job of, proverbially laying crepe and making it clear that he didn't think she was going to survive the hospitalization. And then on the tape, you hear my uncle say, "So do you think she's going to need a walker when she goes home?" And the level of disconnect in that conversation was really striking to me. I think that the ability to use visual tools and videos and multimodal information to engage patients makes it much easier to make sure that you are truly communicating with them in a way that they understand and realize when you're not, as opposed to the historic way of approaching this.
I think, as with anything, whether it's shared decision or our EMRs, I think as much as it's posed many challenges and it's helped us, I think it's exciting because it's very dynamic. And I think we're going to see in imaging, this is coming up for CMS January 1st for the shared decision making for all our radiology centers. So it's going to be interesting to see how this rolls out. So I think the potential is great, and that's what's exciting about it. And I think there's always a period, constant transitions, and it's getting better. I remember when Epic first came out and how it looked to how it is now. It is better. It's far from perfect, and it will never, none of these tools will ever be perfect. But I think whether it's shared decision or anything, I think it's really, you have the engineers, that are the tool makers, and then you have your users. And I think it's really engaging your users to make sure. One of the things I always tell people is, if I have to go to training to use any sort of tool, it's really not where it needs to be. I should be able to go in, open up a system, and navigate without any training. And if there are any engineers in the room, that's what I would say.